Good morning, everyone. Thank you for joining us this morning. We're here to talk about study budget negotiations. My name is Lori Rich. I am the VP of Financial Operations at Elligo, and I oversee our operations and strategy for our financial management services. When I started out in research, I started with contracts and budgets, so this is a topic that's very near and dear to my heart.
Good morning, everyone. My name is Cassidy Duffany. I am the Manager of Operations Finance at Elligo. My day-to-day responsibilities are centered around the financial aspects of clinical research, specifically in AR management, including payments and invoicing. I am also responsible for team management as well as budget and contract negotiations. Over the last 2.5 years that I've been at Elligo, I've negotiated hundreds of clinical trial budgets, which is what we're here to talk to you about today. So as I just mentioned, Lori and I are here to discuss some of the important information that you need to keep in mind when working on a clinical trial budget. There are multiple things you need to consider and understand in order to even be able to start that negotiation, including the type of budget you are working with, understanding how to review the protocol, your procedural as well as site level and patient level costs. You also need to understand what conditional items you want to ask for and what the desired payment terms are for your site. Each of these things will help you determine if the study is feasible for your site, and if it is, and you move forward with that negotiation, you will then have to finalize that study budget. Now we'll talk about the different aspects of these throughout the rest of this presentation.
So first, we're going to discuss the two different types of budgets that you'll see. So first, we have our blinded budget. So you can see this in two different ways up here. So when you have a blinded budget, it's not going to be as transparent. So you're not going to be given the procedural values. You're only going to be given the total cost per patient. And so with this, there is a little bit more due diligence that has to be done in order to ensure that you're covering all of your costs. So you can see here on the left, we have one where it does list the procedures, but you have X's in them. So it's indicating that there is a frequency that these are going to occur. However, it's not telling you what the associated cost is. And on the right, we have one that shows you just the total visit and then the subject stipend and the total amount. So when you're doing this, you do have to review and create your own internal schedule so that you know what your cost should be for each of those visits. Do this. Just the arrow. So next we have unblinded. So unblinded is a little bit easier. So this is where you get full transparency. You're seeing all of your procedural values, you're given all of the costs, you understand where the total budget came from and what the sponsor, the CRO, how they determined those costs, and then you can then cross-compare that with what the costs are for your individual site. So you want to make sure this too, that you're reviewing it very closely. Because you will see that sometimes different line items will have multiple items within it. So we want to capture those costs. And again, this one is a bit easier and it does allow the negotiation to proceed much quicker because there's better understanding of where maybe there's some gaps between where your budget's coming in and where the sponsor came up with their budget.
So when you're working on building a budget, the protocol needs to be your point of reference. There are 4 main things to consider when evaluating your protocol. The first is your overall study design, which will tell you the phase of the study you're working with, the demographics of the patients you are evaluating, as well as the type of study. The second thing to look at is the schedule of assessments, which will tell you all of the procedures, cohorts, and sub-studies that are associated to each study. The third is the footnotes, which will give you specific information about the studies about the procedures being conducted, including the frequency that each procedure may be performed. The fourth and final thing to look at are any uncommon procedures such as scales or imaging that may require additional time and effort from the site. We'll talk about the intricacies more on the next slide. So as I just mentioned, the overall study design should be the first thing that you look at when beginning your review of the protocol so that you understand what you are actually negotiating. The phase is your first indication as to how much time and effort will be required of your site. So a phase 1 study typically requires more time and effort than a phase 3 study. A phase 1 study also implies that we'll be looking at a smaller number of patients, whereas with a phase 3 study, we expect to enroll a larger number of patients. Phase 1 studies may also include inpatient visits, so it's important for the site to know if they have an inpatient facility for these to take place at, or if they need to utilize a hospital for these. Whenever we're reviewing a protocol, we do want to ask, what is the study that we're looking at? Are we evaluating a drug or are we evaluating a device? We want to know who is our patient demographic, and will a caregiver be needed to support our patients at their visits? Depending on your answers, these questions will give additional information as to what may need to be included in your budget. Now, the schedule of assessments needs to be your point of reference, whether you're working with a blinded or unblinded budget. The SOA, so to speak, is your meat and potatoes when you build out this budget. So if you're working with a blinded budget, you need to export your schedule of assessments into an Excel spreadsheet and then tie a revenue to each of the procedures being completed. If you're working with an unblinded budget, you need to ensure that all of the procedures in the sponsor-provided budget grid are included in your schedule of assessments. And you need to ensure the opposite, that all of the procedures in the schedule of assessments is also located in that sponsor-provided budget grid. Cross-comparing the procedures and the specific visits that each of these are taking place at is essential in ensuring that we have an accurate budget. Now, you also need to know if there are sub-studies or cohorts in this protocol which you will be participating in. Typically, we see sub-studies for things like PK sampling or photography. You also need to keep in mind that if you're evaluating multiple demographics in one study, so multiple age groups, for example, that there may be a separate budget grid to negotiate for that separate age group. So just be careful when you're reading through that. The final thing to be really careful of is the frequency that each procedure is being completed at, and typically that's found within the footnotes, which Lori will tell us more about.
So many times the footnotes are going to give you that additional kind of almost hidden information. So you want to make sure that you read all the footnotes very carefully. So a few prime examples where we see this is with ECGs. So a lot of times ECGs will be done in triplicate. So if you're looking at the ECG and you see the little Roman numeral next to it, get to the associated footnote, it's going to tell you that your procedure has to be done 3 times and not just once. So we need to make sure that we're covering the cost for that to be done 3 times rather than just the 1 time. The other area that's really important to take a close look at is going to be with the study drug administration. So with your study drug administration, it depends on the protocol, so it is very specific, but a lot of times in the footnotes, it will tell you how long the patient's going to have to remain on site after that drug is administered. So this could range from 30 minutes to 4 hours. So you want to make sure that we're able to assess that and make sure that the site is covering their costs, and then also the patient is being compensated accordingly for their time and effort to participate. So those are 2 main ones. Definitely keep an eye out for, but it's really important to read all of the footnotes because that's where you're going to find these details that are going to be really important to making sure that you're covering all the costs. So our next item is uncommon procedures. So uncommon procedures, you might have things like imaging or different scales that aren't as common. But for imaging, you want to make sure that we're getting the actual direct cost that is going to be associated, because for different types of MRIs, those costs can vary greatly. So you want to make sure if you're working with an outside facility that you gather those costs prior to agreeing to a cost for a particular study. And then not only do you want to cover the cost for the direct cost that you have, but then you also need to think about the admin time that's going to go into that, because each time you're coordinating with this facility to have that patient go there, there's going to be time and effort spent trying to coordinate that and make sure that everything is going to be working within the protocol compliance and with the patient and what they're able to participate in. So very important. And then for scales and questionnaires, you want to make sure that we're looking at what the rater requirements are going to be. So particularly with CNS studies, you're going to see a lot of these scales. And you want to make sure that if a rater is required, that you, one, have the rater that is certified for those scales. And then do you need one rater? Are you going to have 2, 3 at the site, depending on the size of the study and what those requirements are going to be. So you want to just make sure that you're getting reimbursement and associating any costs that are going to be specific to that study for those uncommon procedures, that they're being accounted for. So you really need to look at the overall picture of what's going to need to be done in order for this protocol to happen at the site.
Now, your per patient visit fees are the most important area of your cost per patient budget, as this is how you will be reimbursed for the time and effort that it actually takes to complete the study for each patient. So fair market value is a term that you'll hear frequently throughout the negotiation process. However, it is a little bit different in clinical research than it is in other industries like medical billing or insurance. They use CPT codes. The fair market value to complete a procedure at your site does have some variability depending on your location, your demographics, your infrastructure, and the protocol that you're working on. The indication will also play a big role in determining costs. For example, the time that it takes to administer an informed consent for an atopic dermatitis trial typically is a lot less for both the site and the subject than administering an informed consent for, say, an Alzheimer's trial. Depending on the indication, certain procedures may also require PI completion rather than coordinator completion, and this will also bring an increased cost for those procedures. Now, for your outsourced fees, so this is local labs, imaging, supplies, or ophthalmology, we actually recommend that you don't include these in your per patient costs and that you move these down into the invoiceable section. And this is for 2 reasons. One, so that you can track the direct costs of your site, but also so that you avoid increasing your cost per patient. Many sponsors have a set cost per patient that they can't go over, and these outsourced costs tend to increase that above that limit. So removing those gives you a little bit more flexibility. The last thing I want to touch on here is overhead. So it's really, really important that you know the overhead costs of your site. It's meant to reimburse you for your business expenses, so your building costs, your utilities, any indirect staff, or any other expenses that are not directly related to one specific protocol. Many times, sites will use their overhead during times of financial hardships. So right now, during times of really high inflation, many sites are increasing their overhead over what it was last year to account for that and to provide a little bit more of a financial cushion.
So our next item is going to be our site level fees. So site level fees, these are items that are specific to a protocol, but not going to be specific to a patient individually. So for instance, if you have an IP that is going to need to be stored, you're going to have a pharmacy fee, versus if you have a device study, that's not going to be applicable. So this is very protocol specific, and you need to take a close look at that. Same thing here with rater training. I know I brought this up on the last slide, but rater training is another one that you want to make sure that you're accounting for that, because some of the rater certifications do require a lot of hours of training. So you want to make sure that that is also included. Another example is CTMS. So CTMS at a site, it is a direct cost for that study. So for each study, typically, you're going to have a direct cost. So you want to make sure that that's going to be covered so that you're able to track throughout the life of the study. Another one is document storage. So document storage, a lot goes into this. So here we see 2 big items, and it's going to be the number of enrolled patients, and then you're also going to have the length that the documents have to be stored. So if you have a study and you enroll 10 patients versus a study you have 100 patients, you're going to have a lot more documents to store. And then same thing with the number of years. So some studies require 7 years, some require 15. You're going to have a very different cost associated with those lengths of time. So we need to make sure that we're covering those costs. And these site level costs are typically one-time fees that I'm talking about, and usually they're at the start or the close of the trial, depending on what they are. So when we're thinking about this, I'd say the easiest way to start to determine what the associated costs are going to be is to look at your time and effort that's going to have to go into each of these, and have a cost per hour that you're associating with your site, and then just multiply that by the number of hours that it's going to take to complete this. And then for actual direct costs, you want to make sure that we're covering those. So next we have the recurring site level costs. So these are for ongoing maintenance throughout the life of the study, and these are going to be more than one time. So as discussed on the last slide, if you have IP, you're going to have a pharmacy fee. Now, if this study is going to go 2-3 years, you may need to ask for either a quarterly or an annual maintenance fee because you're going to have to upkeep with the pharmacy. And you want to make sure that you're accounting for all those reimbursable efforts that are going in that aren't covered in the cost per patient. And it's going to help you maintain compliance. So you want to make sure that you're compliant with the protocols, and that's really important. So that ongoing maintenance cost, that's where we want to make sure we're covering those items. So you see here, we have a list of some of the frequently requested items, and you want to make sure that these different items are covered here. So if supporting documentation is needed, you want to make sure that you have a way that you're tracking that on an ongoing basis, because it's much easier to track on an ongoing basis than it is to then backtrack into that and have to go and find an invoice that you paid for 6 months ago. So make sure that you're tracking things on an ongoing basis. It'll make things much easier, and it will get you reimbursed a lot quicker. So when you're preparing the budget, you want to think through your costs and make sure that anything that's associated with conducting a specific study is being covered here. I can't reiterate that enough. It's just these things are not covered in the cost per patient, but are directly related to the study at your site. And I'll end this slide just with, make sure you do have letterhead ready. This is something that is typically required. And so you want to have your rationale, your supporting documentation when you're requesting these during your negotiation, ready to go. It will help expedite the approval process, and it will allow you to work a lot quicker with the sponsor and CRO that you're working with.
So contingent fees are fees that may or may not occur, and they sometimes depend on the type of study being conducted. When you're negotiating your contingent fees, be sure that you're referencing historical information. So whether that's another budget for the sponsor that you did previously or an entirely different study, you want to make sure that you are capturing all of the expenses that might come up throughout the course of the trial. This is one of those sections that additional documentation is normally needed by sponsors. So if you're working with an advertising company and you get an invoice for $5,000, the sponsor will want to have a copy of that invoice to prove that you did actually incur those costs. Aside from receipts, they may ask for specific information. So this may be the specific date that an SAE or a protocol amendment has occurred. One contingent fee that we always try to get approved on our budgets is pre-screening. So this may include calls or chart reviews. And this is time that's not included in your cost per patient, but it is really, really important. Including chart review or calls for pre-screening in your budget may reduce your risk of screen fails as you're pre-screening and talking to these patients before you actually bring them in for that screening visit. On the opposite end of things, patients who are lost to follow-up require a great deal amount of effort from the site, as they'll have to call these subjects multiple times in an attempt to bring them back in office for these visits. Again, this is not included in your total cost per patient, but it is essential in attempting to keep all of your patients enrolled in the study. Now, as I mentioned briefly, that the sponsor will typically require that you provide that third-party documentation. If these fees are included in your budget, be super, super organized throughout the course of your trial. If you don't have the documentation that they are requesting, they will decline payment for these. So be sure that if you do have these in your budget and you do use these fees, that you have documentation on file to send out when you invoice the sponsor for these items.
So our next topic is going to be the payment schedule terms. So you want to make sure that we're paying close attention to these so that the terms you're desiring for the trial are being addressed. You want to make sure that you are able to cover your costs and maintain a healthy cash flow. I know this is a big problem for a lot of sites, is the cash flow portion. So when you're thinking about it, think you're paying the subjects as these visits occur, and you're paying your site staff probably on a biweekly basis. So you're outputting these funds irregardless of whether a payment is made during that time frame or not. So we need to make sure that payments are being made as frequently as they can. We always aim for monthly payments, and this has become a lot more widely accepted now that EDC has really become the standard. Previously, we would see that on-site monitoring would be required for payments to be made, and now since we do have EDC, payments can be made a lot more frequently. So same thing here with withholding. So withholding previously, a lot of times we would see that there's a lot of pushback because the sponsor wants to have some liability with the site to make sure that they're going to complete their source and have that completed. And again, now with EDC, this can be reviewed more frequently. So there's less liability there. Yes, on-site monitoring still does occur, but there's a lot of remote monitoring that's also happening on an ongoing basis. So we want to make sure that we're paying close attention to this. Try to keep it to a minimum. And then if you do run into this, you want to make sure that it's a minimum, and you can also request a cap. Because say you have a very high enrollment number and there's a withholding of 10% on every visit, that can easily add up to a substantial amount of money. So we want to make sure that, one, yes, we're providing that consistency for the sponsor if it's needed, but then also making sure that the site's being paid for the work they're completing as much as possible in a timely manner. Same thing for invoice items. So invoice items, you want to try to mirror the terms. So if you're getting monthly payments for your visits, you want to do the same for invoices. There are sometimes different terms here because you're going to have different processes for the invoices to get approved. So we do aim for 30 days, but 45 days is still very fair. And then language. So language is a big one. So when you're going throughout the negotiation process, you're agreeing to these terms, you think, okay, we're on the same page. Then we come to the contract. The contract might say something that looks similar, but it's not exactly what you thought you agreed upon. So you want to make sure if you're saying, okay, we're getting paid in 30 days, it's 30 days from the end of the prior month, not 30 days from monitoring or quarterly from the end of the month. Because now you're really not at 30-day terms, you're at 60-day terms, 90-day terms. And now at the same time, you're thinking the site is outputting this money while they're waiting for payment. So cash flow is really an issue that we do see pretty frequently. So again, reiterating, subject visits based on EDC, not monitoring. Always really try to review that closely. And then for screen fails. So screen fails, we always start by requesting for all the screen fails to be reimbursed. So screen fails, the site's performing work. They're bringing these patients in. We want to make sure that they're being compensated accordingly. But a lot of times there is a ratio in effect, and it's there for a reason. So when we're looking at this, we want to make sure that we're determining where the patients are going to be screen failing at. Is it something that we can do pre-screening and reduce those amount of screen fails, or is this going to be something where they're doing labs, say on site, or there's imaging, and now these patients, we can't determine if they're going to really qualify until they come on site. So, and you want to keep track of these things, because if you do come into an issue where you've hit your ratio and you need to request additional reimbursement, you want to know why these patients screen failed, right? So when you're working with the sponsor, you can explain these patients came in and because of the labs, they weren't able to be randomized. And then that allows them to have a better understanding too of why the request is being made. So tracking is very, very important. And we always aim for either having the screening, if it's a screen fail patient, either have it paid at the cost of the visit or on a per procedure basis. So per procedure is very fair. It's fair for both parties because you're being compensated for the work that's being completed, and the sponsor isn't paying for work that wasn't completed. So both are very fair. And just to end this portion of it is you want to make sure they're paid as they occur, not at the end of the study. For the work that's being performed, the study might go 2-3 years. And if you're not being compensated during that time, again, this causes a cash flow issue.
Now, to wrap things up, once you have reviewed your protocol, you know all of your expenses, all of your costs, and all of your requests, you want to provide everything in a clearly outlined email to the sponsor or CRO exactly what you are asking for. If you do think that supporting documentation for any of your requests will be requested by your contact, be sure that you provide that in your initial email so that we don't delay the negotiation process down the line. Typically, we see about 3 rounds of negotiations, at which point we request that a call take place that we can talk through any of the remaining items. We've found that a lot more progress is made when you talk through something and explain your reasoning for it versus continuing with the back and forth through email at that point. If you do have fees that aren't being approved by your contact, ask that your budget be escalated. So if you're working with the CRO, you can escalate the budget to the sponsor. If you're working with the sponsor, you can escalate your budget to the clinical trial manager. And if things are not being approved, make sure that you tell them this is what you need for it to be feasible at your site. If this isn't accepted, then you can't do the study. It's really important to have that transparency. Once you do have everything agreed to, be sure that you QC all of the documents before signing. So you want to make sure that all of your payment terms, again, as Lori mentioned, match the wording in the contract, so that everything is consistent. And you want to make sure that everything that you negotiated in your budget has been transcribed properly in that final version. Once everything has been QC'd, you can request those signature-ready versions and route for signature at the site. Once you have the site signature as well as the PI and sponsor signature, you can execute the study and move forward with conducting it. So we hope that this provided some information and some clarity about the important things that you need to look at when working on a budget. And we will be around after the presentation. I know we're cutting it close on time here. So if anybody does want to talk one-on-one or have any specific questions, we're happy to do so. Thank you.
Okay.
Hello, thanks for the presentation. A quick question about some of the site level costs, specifically like training costs, pre-screening, data mining. Do you ever see that lumped into startup fees, or do you typically break them out?
So we typically break it out because there's a lot that goes into startup as it is. And again, that's why having your rationale is really important, because when you're splitting up these costs and identifying where there's specific cost areas, it's really important that you do outline, no, this isn't included in the startup. This is included in the startup, so that you do have transparency throughout your negotiation. But we typically break them out.
Okay, thank you.
Yeah.
Is there a certain CTMS or platform that y'all use to extract your budget?
So we do not use a CTMS to extract our budget. We do all of our budget work manually. So we reference the protocol and go through everything. It does take time, but doing it with just you and the protocol, you know that you're catching everything and you're not relating on the data to be missed in any way.
Thank you.
Quick question on your blinded and unblinded. What's the rough split in your experience?
The rev split?
The split between, it really depends. I mean, certain sponsors primarily work with blinded budgets and other sponsors work specifically with unblinded budgets. So, I mean, we see both on a weekly basis. I think unblinded budgets are typically more common because there's a lot more transparency there to work with. But again, there are many sponsors who specifically do blinded budgets and there's no unblinding.
Okay, so more unblinded than blinded in your experience?
Yeah, for me, but again, it depends on the sponsor. So if you're working more with a sponsor who has those blinded budgets, it would be different.
Okay, thank you. Any more questions, please?
In the case of the blinded budget, obviously that creates a lot more administrative burden on the site team to break it down properly. In those cases, I've, been trying to then actually add that as a justification to increase the startup fee, bringing it back to them, because tactically all they're doing is slowing things down, because any good site's going to have to break it down, and that takes a long time. So is that something you guys have tried and been successful with? What type of increase in the startup fee have you applied when you receive a budget that way?
Yeah, so our startup, it does include the negotiation. It does take a little extra work, but we do always aim to get, the most for our startups as we can, to be covered. And that is one of the items that is in there, yes.
Apologies in advance for my voice. I'm Paige Nimchek, head of contracts for IQVIA. There's a lot of new technology, of course, coming out these days that both sponsors and CROs, ourselves included, are asking sites to use. Are you putting that into your budgets actively?
So you're saying for technology for ongoing in the study or for the negotiation?
For the negotiation and for ongoing.
Yeah, so we typically ask that we do not do it within a portal. We found that slows down the process even further. It's much easier to work with somebody one-on-one and talk through the budget and email versus the portals. I understand the rationale in trying to go more electronic with it, but at least in my experience, it just slows down the startup process. Thank you.
Any more questions? Okay, thank you very much. It's a great presentation.